Recording. All right, welcome everyone. This is a special edition webinar for Synapse Care, and we're really proud of the partnership that we've had over the last few years with Lifelines, and have created kind of a deeper relationship regarding education and kind of corporate relationships. And so we are really excited that they chose this topic because first off, aEEG is a huge passion of mine, so bedside brain monitoring in general. And of course, we all know that getting the electrodes on is one of the most difficult and kind of the Achilles heel of bedside brain monitoring. And if we don't get that right, we don't get a good signal, and then there's really no monitoring and no benefit for us and for our babies. So I'm really excited that Melissa and Jim are here with us today to present on this amazing topic. And so I'm going to just do a really quick intro of them, and then they'll continue to kind of expand on how they got involved with where we're going and explain kind of the overview of today. So actually both of these individuals are EEG techs, and who better to teach us? So assuming most of you out there are like me, not EEG techs, and who to teach us about electrode placement and electrode management and really creating great solutions than EEG techs. And so Melissa actually comes from her experience in the NICU, coming all the way back from many years from Rainbow Babies, and then now she's in California, and she worked as an EEG tech, but now is working full-time as an educator and as a solutions provider for NICU nurses and technicians. And then Jim was also an EEG tech, but he comes from Dublin, Ireland, and you're going to be able to hear his amazing career story. And just a little kind of spoiler alert, he invented this amazing product. So how cool is that? So Melissa, I'll go ahead and let you take it away, and thank you to Lifelines for creating this opportunity to share with our Synapse Care community.
Thanks, Kathy, so much. I really am honored to be here and having this opportunity to talk about the Incereb Neon. And before I get started, I'd like to pitch it over to Jim to just give you a little background on himself and how the Neon became one of our options that we use.
Well, hello everybody. My name is Jim Roach, and I'm dialing in from Dublin. So I'll give you a quick weather report. It's raining, and I suppose my story is a kind of an odd story. I'm kind of an accidental inventor, really. I started off as an EEG tech in Ireland and worked in the UK for a while, and I worked for a long time with Geraldine Boylan in London and in Cork, both clinically and through industry. I worked in sales for another company that we shall remain nameless for a little while. And Geraldine was developing algorithms for looking at brain waves to be able to detect seizures before they start. So this was a big project that started in Cork in 2006. Just after brain cooling really became a therapy here in Europe. And this was a group she set up called the Neonatal Brain Research Group, looking at software to analyze EEG to make it easier for non-neurology clinicians to interpret. And at the time, I had sold the EEG systems to her that she was using. And over coffee one day, she said, you know, the biggest problem is that not everyone has access to EEG techs. And the biggest problem we have with analyzing data is that we're not always sure if the data we're seeing is accurate, if the electrodes have been put on correctly on babies' heads. One of the things about EEG is that the electrodes need to be symmetrical on the left hemisphere and the right hemisphere of the head. That's probably the most important thing. And she said, we're not always sure that's the case. So I said, you know, maybe somebody should come up with a better way of putting EEG electrodes on, especially on babies, you know, if you have to get them on as quickly as you say them before. So she went, well, that's a job for you, and off you go. So on the back of an envelope, I sketched what I thought was a design that would work. And fast forward 6 years, and you know, $3 million of raised venture capital later, and a company formed and eventually sold to Lifelines, which is why I'm here today. We have the Neon device, which is it's a way of getting electrodes, multiple electrodes, onto a baby's head very quickly, and with really very little training. That's safe for the baby, Doesn't involve using needles. And what it does is it puts an array of electrodes on the baby's head. Comes in two sizes, and those electrodes are symmetrical, which is the most important thing. But they're looking at the EEG patterns from the left side of the brain and the right side of the brain. Babies' brains are unusual in the world of EEG. A lot of little quirky things show up in EEG patterns that in an adult would seem to be abnormal, but on a baby, they, depending on the number of them and the interpretation, they're passable as normal. So it's quite a different test to interpret. But being absolutely sure that you're comparing left hemisphere to right hemisphere accurately is the most important thing. And a secondary issue, and just as important, is the care of babies in the ICU. From a parent's point of view, from a holistic point of view, parents are obviously very upset when their babies end up in an ICU, and babies have wires and tubes and machines and everything all around them. And EEG a full EEG in a baby is really not a pleasant thing for a parent to have to see when all these wires are stuck to a baby's head and the head is bandaged up. And we tried to design something that would be less scary for parents when it's sitting on a baby's head, and certainly something that wasn't subdural needles. So we, as a company, we're based here in Ireland, and we have a long working relationship with Geraldine Borland's group here in Cork. We used Lifelines in the US as our US distributor from 2016. And around that time, and Melissa, I think you joined in mid-2016, was it around that time?
I think 2017, yeah.
2017,
yep.
And Melissa has become far more expert in the use of neon than I ever was, I have to say. And then Lifelines bought us in October 2018. So now we're all part of the one company, which is great, I have to say. So that's my little brief story. So I'm going to pass you on to Melissa now, who's going to lead you into the world of the Incereb neon.
Thanks, Jim. And I wanted to just let everyone know that as an EEG tech, I am very passionate about the Incereb neon. I think that it's an excellent tool to have in your kit to use as an option with your neonates. I know many of you on this call are nurses, NICU nurses, and you're probably currently using either hydrogel electrodes or possibly needle electrodes. So I'd like to just introduce the Incereb neon as a possible another step in your toolkit, something else you can use. I know that as an EEG tech, not every electrode works on every baby in every situation. So you may feel that you want to use this every single time, and you may decide you want to use this on specific patients. So another thing I'd like to say is anytime you have a question, feel free to just jump in. I'd like to have an interactive session here, and we'll go ahead and get started.
Melissa, let me just quickly just give everybody an orientation. So if you guys do have questions, you can put it in the Q&A or in the chat. I'll monitor both. And then do you want to know how many people are nurses versus staff?
Sure, I'd love to.
Oh, great. So you guys, you want to put in the chat area, nurse, tech, maybe where you're from? So nurse, tech, Illinois, Texas, Manchester. Oh, wow. Good night.
Woo.
Pennsylvania.
We're global.
That's the coolest thing about webinars, right?
Yeah.
Hi, Leah. Hi, Liz. Estonia, pediatrician. Awesome. Wow, this is really cool.
You're bringing us all together, Kathy.
I love that. My favorite part about webinars. All right, we'll let you take it away.
Okay, so the Incereb neon was optimized for the NICU, as you also heard from Jim Roche, and designed by the EEG tech himself on the call. You can use this electrode array from birth. So there's no cutoff, the baby's too young. Basically, you just have to decide as a bedside staff if you think it's okay to use on your baby like you would any other electrode. The nice thing about it is it's a quick application by the bedside staff with very little training. As you can see, it's an array, so there's no measurement, which I know can be very cumbersome to do. And the goal for EEG monitoring or aEEG monitoring is symmetrical placement every time. So as long as you have the electrodes on the left hemisphere and on the right hemisphere in the same spots, you got symmetrical placement. You're comparing apples to apples on your EEG, and that's exactly what you want to do. It's obviously non-invasive. There's no needles. So that always is nice because it's eliminating any unwanted needle sticks to the baby, the nurse, or possibly the parent that may be trying to hold the baby. As I've been training many, many nurses over the last few years, one of my things that they've told me is it's sometimes difficult to remove the needles or even the hydrogel. They've been taped on the head and they get kind of sticky over time, and that can sometimes overstimulate the baby. So this is another nice option for the Neon. It doesn't have to have any tape. You'll see in another slide that we'll just put a little netting over it and it holds it on very nicely. It can also be used for a short-term recording, an hour or two, or it can be in long-term recordings up to 3 to 5 days. So this is what it looks like underneath. There's the top version on the right, and then you see that next to it underneath. There's no paste on this one, but you can kind of see this is what it looks like before there's paste applied. This does come with paste already applied in the electrode cup. We use gold standard 1020 electrolyte, which is also working as an adhesive paste. Again, there's no measuring, which saves time and sometimes decreases overstimulation. As we all know in the NICU, one of the goals we want to do is decrease overstimulation to our infants, especially the high-risk preemies. We also use gold standard New Prep skin prepping gel, which has been around the EEG world for, geez, at least 30 years, probably longer. And I've found that it's my go-to. It's the easiest on the skin, and it's been tested so long. So that's one reason I like the Neon as well, is we're using gold standard things that the EEG techs have used for 30 years. So it's not a brand new type of product. The other thing you might notice when you're looking at the electrode array is it's a soft foam-like array, which is really comfortable for infants. Another thing I know we're all very aware of is pressure points or any skin irritation or breakdown. This is very soft. If the baby lays on it, it's not going to give you a pressure point. It's not going to give you skin irritation. It's very flush against the skin. And this is also single use only, one baby, and it's FDA approved. And you can see down here at the right-hand side, I have, this is the Neon 6, actually the Neon 8, excuse me, and it has 6 recording electrodes, which are F3, C3, P3, F4, C4, and P4. And then in the midline, it's got a ground and a reference. And this will fit less than 32 centimeter head circumference. And then there's a little wiggle room in there that you can decide, you know, at the bedside, if you feel like it's the right size for your baby. We also offer another size, which I'll show you coming up. The one thing that we're really proud of is the Incereb Neon 8 and 12 are both designated as Vizient Innovative Technology products. We've been awarded this, which we're very proud of, because Vizient reserves these contracts for technologies that demonstrate an ability to enhance clinical care, patient safety, and improve an organization's care delivery and business model. So we had to make sure all those things fit into that before we were awarded this, and we're really proud of that. The Neon electrode array itself is a one-time use. However, we have a reusable Neon cable. There's a cable for the Neon 8 and a cable for the Neon 12. These are reusable, so you don't want to throw them away. You would clean the cable between patients just by using whatever SteriCloth you guys use in your NICUs, antibacterial, wipe it down. They will work with any CFM or EEG equipment. So when you're shopping for this, you will just need to know what type of system you're using it on. Many of you I know are using the Brains monitor or different types of CFM monitors like that. So your real option only is the Neon 8 because you only have an opportunity to use I believe, 2 channels. So that'd be 2 electrodes on each side of the head. So the Neon 12 would be a little bit overkill for that type of system, and more EEG techs or people that have EEG equipment in their NICUs will want to maybe go with the Neon 12. This is an example of the Neon 12. You can see it has more electrodes, and it fits head circumference of greater than 32 centimeters. And again, it's compatible with all the brands of CFM with aEEG and EEG systems. And the recording electrodes are F3, F4, C3, C4, T3, T4, T5, T6, O1, O2, and then again, it has a central ground and reference electrode. And if there's any questions, someone please just feel free to jump in anytime. We all know in the NICU time matters, especially if the baby is compromised and it's an acute situation. So this is yet another reason you want to get those electrodes on the baby as soon as possible, symmetrical, with very little discomfort, and recording EEG as soon as possible. And most of the time it takes about, I would say, 10 minutes on average to put this on. Obviously, if the baby's moving a lot or if there's a lot of hair, you'll need to part the hair. But what I like to recommend is each nurse will grab a buddy so you have help, and somebody can help hold the patient while you're applying the electrodes, and that usually works pretty well. Advantages of Neon. Some of the ways sites are using this is as a bridge or a stopgap when there's no EEG tech available to begin the recording. I know some sites have full-time EEG techs, and other sites don't have any, or they're only there during the day. So I've trained a couple sites now where when there's no one on in the evening, the nurses are trained to put the Neon electrode array on the baby to get that monitoring as soon as possible. And then in the morning when the tech comes in, they take that patient over, and they may even take the Neon off and put on a full set of EEG electrodes or whatever their protocol is. Another thing that's nice about the Neon is you can leave it on as long as you need to. But as we all know, these babies are sometimes in isolates with high humidity levels, and it can cause the paste to kind of melt or get very soft. So what you're going to want to do is about every 12 to 24 hours, you're going to want to check the electrodes. You're going to want to make sure that there's no salt bridging. And by that, what I mean is if the paste from one electrode leaks into the other electrode, that's going to cancel out your signal and give you a flat line on your EEG or your aEEG. And you don't want that, because that's a false positive. That's not really the baby's brain. It's just that that paste leaked together and shorted out those electrodes. So what you would do if you see that happening is just get a little alcohol swab, clean off the skin in between the electrodes, make sure there's no electrolyte paste touching. And you may also want to add a little bit more of the 1020 paste underneath each electrode, especially if it's kind of melting or getting a little bit soft. This is also another way that parents can be a little less frightened when they see the Neon on the baby as opposed to needle electrodes. And then a lot of sites I know aren't allowing their parents to hold the baby with the needle electrodes, which I know as a parent, for me, it would be difficult not to be able to hold my baby. And I know the whole bonding and skin to skin thing is a very important thing in the NICU. So if you do have that rule in your NICU, this may be a way around that to get the parents to be able to comfortably hold their baby and without the worry of getting a needle stick. As you can see here, there's no tape that's holding the electrodes in place. It's being held by the 1020 paste as well as the Surgilast netting over the top, which is nice because you can still let the skin breathe and it's not really tight on the baby's head. And all of this comes off easily with warm water. We recommend that after you prep the skin, the impedance is below 10 kiloohms. And again, we highly recommend daily skin checks every 12 to 24 hours, following your hospital daily skin check protocol. And if you don't have a skin check protocol, we have a really nice handout that's best practices for daily skin checks and maintenance for neonates undergoing EEG monitoring that we can send to you that can help you come up with your own protocol for your unit. You do need to remove this for CT, MRI, and a lot of times head ultrasound. So just so you know that it can't go in those. So it will have to be put back on when the baby comes back in. But again, it's no needles, there's no tape, so it's pretty easy to do. And it's not very painful, and it doesn't take up very much time. We also have some Incereb video tutorials, and we can send you the links to those. And those are a couple of our handouts that we have. One that is the size of the orange, of an orange, and the best practices. So what I'd like to do now is ask if there's any questions or anything anyone would like to ask, and then I would like to show you guys a brief video, and we can take more questions after that.
So one question did come up from Anne, and she was asking about if you have a brain Z, so if you're in a situation where your EEG tech only runs, or your EEG department only runs a big EEG, and you run your CFM or your aEEG as a second monitor, do you have the ability to split the signals off of the connector cable so that they could still run both, or what would you recommend for her?
Okay, so just to clarify, are they hooking up the baby with EEG electrodes?
Yes.
And what is she doing now? Putting needles in around them?
I believe so.
Okay. There is a way to jump those cables. The EEG tech would have to kind of take that and run with it. They should know how to do that into the two different machines. But I think for me personally, the less amount of electrodes on a neonate's head, the better. So if you can share them, that would be the goal. And there is definitely a way to do that. There's just a jumper cable that would go from electrode to one electrode to two pieces of equipment.
Perfect.
Yeah.
And does that answer your question? If not, let me know and I can ask it again. So Mary is asking, you know, the million-dollar question: how does it stick on babies with lots of hair?
Well, as an EEG tech, you know, there's not one patient I can't hook up. You just got to part the hair. So I'll show you a video of how I would recommend it. I usually, again, recommend that you have another nurse to help you. You part the hair, and they can kind of hold the hair apart, because I know neonates' hair can be, or newborns' hair can be just sticking straight up, and it's not cooperating. You just got to get to the scalp, part the hair, prep the skin. You'll wipe the prep off, which is a very important tip that you need to do. If you leave the skin prep on, first thing is the electrode won't stick very well. And second thing is it'll increase your risk of skin breakdown because it's got a salt base to it. So wipe the prep off, stick the electrode on, and then move to your next electrode. So you'll do one electrode at a time. Once you get them all on, you'll put that netting on it, and everything should be good. So it does take longer when they have hair, but it's just one of those things. Yeah, needles, you can pop them right in, but it's a needle. So that's the trade-off.
And just to be clear, you're not advocating for shaving.
Absolutely not. I personally would never advocate for that. And if I came in and my baby had their head shaved, I'd probably lose it. So yeah, I would recommend just parting the hair. It's just a skill level, a learning curve kind of thing. And I know the nurses are savvy. They can pick up on stuff really quickly. So if they do it one or two times, they're going to kind of develop their own technique, and it's not as difficult, especially if you have someone else helping you.
Yeah. So I don't know if you're going to show this in the video that you're getting ready to do. Are you going to do the application video? So maybe
yes.
My question will be answered. So maybe we'll do that.
Okay.
Yeah, Mary, it would be the same. You know, just part, scrub, scrub, scrub.
I like that. Part, scrub, scrub, scrub. Okay. You guys ready for the video?
Yeah, let's see
Here we
it.
go. Today I'm going to show you how to place the Neonate on your baby. You'll need a few supplies. The Neon 8 comes in a package that already has a pre-filled skin prep syringe. You'll just need to get a wooden Q-tip and some gauze squares and some tubular gauze roll from your NICU toolkit. Once you've opened the Neon from its packaging, you'll notice that it already comes with 1020 paste pre-filled inside the electrode cups. It has a ground and a reference, and the recording electrodes are F3, C3, P3, F4, C4, and P4. The first thing you are going to do is line up the reference and ground with the midline. Make sure you're standing behind the baby, and you can reference where the nose is and the ears. The C3 and C4 electrodes are going to line up directly with the baby's ears. So I like to place a little bit of the reference and ground, just touch it a little bit to the baby's scalp. And I can see 2 marks where my ground and reference are going to be placed. They're very subtle. If you wanted to add another level of that, you could get a grease pencil or China marker and make a mark also if you choose to do that. I know some techs and nurses like that option. So you would just need to have a China marker or a different type of marker that you have in your NICU. Once you know where that ground and reference are going to be placed, just place a little dab of the new prep in each spot. Get your Q-tip. You're going to rub in one direction, gently holding the neonate's head, and you can feel a little bit of the grit underneath the Q-tip as you rub. That's what you want to feel. Now I'm going to go in the opposite direction here. The reason you only rub in one direction is because studies have shown that the back and forth rubbing creates more friction on neonate skin, and it can cause some skin irritation or possibly contribute to breakdown. Once you do the new prep, you'll want to wipe off the excess prep. And you can still see your little dots. It might be hard to see it on the video, but I can still see where my electrodes are going to go. I'm going to go ahead and place my ground and reference in those spots, again lining up the C3 and C4, and give a gentle push. You don't want to push too hard, but you want to push hard enough for it to stick. Now I'm going to go ahead and prep each electrode as I did just now. Let me just show you a little better angle here. You'll just squirt a little dot under there. Again, prep in one direction, about 5 or 10 times. And wipe off the excess. Press down. You're going to do that with every electrode. And if the baby has hair, you're going to want to use the back end of the Q-tip to part the hair and get the hair out of the way. You want to visualize the scalp, and then you want to, again, go through the same process, wiping off the new prep and pressing down. You're going to do that for all of your electrodes. And then before you plug in your connector, which you can do at the very beginning before you even apply this to the baby, slip that on, and your electrodes are ready to go. So that was under 3 minutes, plus I was moving a little slowly. I didn't rub each one, so on average it's about 5 minutes to apply, and if the baby's moving a lot, it may take a little bit more time. You'll want to check your impedance. With the Neon 8, the impedance should be under 20 kiloohms to start, but as the paste warms up to body temperature, those impedances should drop to closer to 10. If you find that your electrodes, maybe one of them has a high impedance, you would just lift up the netting, lift up that electrode that's causing problems. You can rub a little more prep, squirt it on there. I'll do that for you so you can see. Get a little prep. Don't forget to wipe off the excess. You should still have enough paste inside the cup. If you do need to add more paste, that's totally fine. So sometimes when you're doing a continuous EEG monitoring on these babies or a continuous aEEG, you're going to want to check those impedances every day.
and they may need a little bit more paste, and occasionally they may need to be prepped. So now your baby's ready to be monitored.
Okay, that's the video.
Nice job, Melissa. That was so good to see it in action like that. Obviously, you're a super pro.
Thank you.
So one question came up about, and this comes up, so either you or Jim can really answer this. What about those babies who have caput? What about those babies who have cephalohematoma? What is your recommendation for those kiddos?
Well, I always say that every single electrode situation isn't always going to work for every single patient. If someone has an anomaly, what you can do is you can move the electrode array all the way a little more forward or a little more back if you can work around that. But the goal is you still have to have symmetrical placement left to right. So it's really, you only can move it forward or backward. That's the way I would approach it. Jim, do you have any tips on that?
No, you're absolutely right. I mean, we can't account for everything that happens on a baby's head, and lots of things happen, you know, from having lines in to you know, even shaped heads. You have to just work around, unfortunately, but that's just the way it is. I mean, Melissa's right. You know, the neon is a solution, but it's not the solution. I mean, it's a solution for most babies, we think, but there will be some babies where, you know, you may have to put individual electrodes on. So,
could you speak to kind of what would be tolerable impedances for a baby who has that much fluid? I think what we oftentimes find is that because of that fluid, the impedance is just chronically higher than kind of our comfort level. And
yeah,
can you speak to kind of the physiology that's happening and causing that?
Well, it's a big problem. It's almost impossible to get the impedance down when there's a bubble on the skin or whatever there may be, or a lot of fluid. You don't want to rub too hard with the new prep because you'll cause skin damage. Unfortunately, when reducing skin impedance, you do need to have some hard surface like the skull beneath the skin just to get some purchase with the new prep impedance reduction paste. It's very, very difficult. What I would say is that you're better having all the impedances of all the electrodes sitting high, even at 30 kilo ohms, rather than having 7 of them at 10 kilo ohms and 1 at 30. You know, one of the way the signals are recorded by the amplifiers is that it's better to have all the impedance equal, roughly equal, even if the impedances are high, and having one significantly lower than the other ones. And that's an electromagnetic or electrical field issue where it interferes with the recording. It's an EEG thing. So what I would do if you've got the capability of doing it is to do your best to get the impedance as low as possible. Make sure that all the impedances are roughly equal. They don't have to be exactly equal, but roughly in the ballpark. And if you can increase the impedance threshold on your machine, which I know many of you would find that quite difficult, but if you've got a cooperative EEG department, they may put the threshold up from 20 kilo ohms up to 30 or 40, for example. This is also an issue of equipment as well. With older technology, technology, I'm talking about the actual machines that the electrodes plug into now. So this is the CFM brains machines, the Compumedics machines, there's lots of them on the market. A lot of the technology is quite old, so the amplifiers aren't as good as they are today. So with older machines, you do have to work harder to get the electrode skin impedance down lower. With the newer machines on the market, you don't have to work as hard, and you can get a very, very good recording with high electrode impedances. One of the things Melissa, myself, and Lifelines are working on is to bring a new EEG system to market just for critical care and for neonatal EEG, which has got the Lifelines amplifier, which is a very, very good amplifier. And this was the reason that we partnered with Lifelines in the first place. Lifelines have an EEG amplifier on the market, which is the best on the market, best in the world at the moment. And it's got, and without going full techie here, it's got a thing called common mode rejection ratio. And all amplifiers have this. And it's one of the highest specification of any amplifier in the market. And what that means is that it will tolerate much higher skin impedances to older machines. So that's just something that's coming. It's not here yet. It'll be, I'd say, another 9 months or a year before we have that on the market in the US. But it certainly is.
Fantastic. That's great. So really the message there is balanced impedance versus kind of going for the gold on one of them and having, 3 of them less than 5 and one of them 25 or something.
Right.
More about balance.
Kathy, there's one other thing I'd like to point out too. If you hook up the baby and all your impedances are high, you need to double check your ground and reference. So those will be the ones you need to go back and fix. If the ground and or reference are high, all of your electrodes will be high.
Good point. Really
okay.
Good point.
And once you get those down, then you'll see what each individual electrode really is.
Excellent. Excellent. So can we talk about kind of the array itself really quickly? So most places who are doing aEEG or CFM would have just two active sites. So is there any issue with them only prepping, say, the 5 active electrodes they need and just basically attaching gently with the paste to the places that they're not monitoring? So if they're just doing C3, C4, P3, P4, and they only need a ground but not a reference, is that fine to be able to just prep those sites?
Definitely fine, and that's exactly what I recommend. I know a lot of sites that I've trained in the US so far use C3, P3, C4, P4, and F3 and F4, I just tell them to stick those down to the forehead without prepping.
Okay, so no need to prep sites that you're not monitoring.
Right, and then the other thing I wanted to point out is I know we're used to using the same montage C3, P3, C4, P4, but if you ever want a longer or a double distance, don't forget if you only have 2 channels, you can use F3 and P3, leave the C3 and C4 out, and then you're getting everything in between those 2 electrodes. So I just want to point that out. When you have limited channels, you sometimes have to think outside the box.
Yeah, definitely. And so what people would do is they would take at the terminal ends of where you have where you showed that array of where they would plug it in with the 15 millimeter touch points. So instead of if they prepped the F3 and F4, they would just attach that into their C3, C4 locations on their CFM or their OBM or whatever they're using.
Yep, exactly.
And they would get that longer montage. And I think that is really helpful for those kiddos who have a lot of swelling.
Oh, you cut out.
Really helpful. Oops, sorry, it looks like a call came through. So I think that's helpful to go longer sometimes too when you have those, a lot of that swelling.
Exactly.
Cool. So there's a question, and I think you maybe mentioned it early on, the age limitations, ages or sizes. Can you speak to maybe in your experience when you've trained or some of your customers, how have you, how small have you seen people using the devices, and do you have any guidance on that?
Well, Jim can probably speak to this as well, but it's for any baby from birth. What has to be determined is the bedside staff, the physician caring for the patient needs to decide what's the best electrode to use on this baby that's going to not overstimulate them, maybe not cause an indwelling needle electrode, because you may not even have to rub very much at all with the new prep, or you may just want to rub a little bit with something lighter because their skin is so different. So it's really up to the bedside staff to decide what's best for that patient, but there's no limitations on any age or head size.
Well, I'll just jump in here as well. In the US, it's approved for use from birth. So any age baby, whatever age they are, you can use the electrode. Caveat is the younger the baby, so the more premature the baby is, obviously the thinner the skin is. So you don't want to be prepping too much. The good side of it is that for very premature babies, there's very little prep to do. Really, the skin is so thin, the impedance will always be very, very low, and it involves less handling. In Europe, the CE, which is our equivalent of the FDA, have certified the device for use from 32 weeks and above. And anything below 32 weeks, so a 28-weeker, 29-weeker, can only be performed on the physician license. So it's the doctor that decides, which isn't that unusual. There's many devices, certainly in Europe anyway, devices are used on babies all the time that don't have any specific approval for use in neonates, but it's used under physician license. For example, anticonvulsant, anti-epileptic drugs, none of those are approved for use for neonatal use. They're all used under physician license in smaller doses, obviously. So for anyone that's dialing in here from Europe, it's 32 weeks and above, and in the US, it's from birth. And the only difference, the only reason that 32 weeks was picked as a cutoff point was for skin integrity issues. That's it.
Great. There's a question about how long can you use the device. So once it's applied, you recommended skin checks according to protocol. And then do they need to change it? You know, the complete setup, do they need to change it every so often, or is it for one patient, it can be for as long as they need? And I think you mentioned about, you know, when to rejuvenate the paste. So maybe reiterate that again.
Well, actually, we don't need to replace it. I think originally that was a recommendation, but now over many, many usages and years of testing, you can leave it on just like if an EEG electrode is left on for 2, 3, 4, 5 days. You can leave it on as long as you need to, as long as you have good skin integrity, you're not having any issues, and you got a good recording. So there's really no reason, if it's not broke, you don't have to fix it. But we do recommend that you check maybe a couple electrodes every day, each day checking the different electrodes, just lifting it up, making sure the skin isn't irritated or there's no issues, no pressure points, and log that somehow into your chart. And then as needed, if the impedance gets high, then every day, every 12 hours, 24 hours, you'll want to check the impedance anyway, just to make sure they're good, especially if you're having any questionable recordings. Then you'll fix that electrode, and that electrode may need extra paste, but the others may be fine. So it's just a case-by-case basis, and there's no cookie cutter. As long as you're getting a good recording and there's no skin issues, you're good to leave it on.
And again, just to play devil's advocate again here, the only we've had recordings run here in Europe for 5, 6 days using one electrode. Obviously, incubators get very, very warm, so just keep an eye that, and the paste will melt at 40 degrees centigrade. I don't know what that is in Fahrenheit. So just keep an eye that the paste doesn't melt. You'll see that. And it really only happens when the baby is under any kind of heating now, which I know isn't, you don't always, it might be the most common scenario, but if the baby's under a heating lamp, then the paste will melt a little bit faster. So just keep an eye on that. That's all.
Excellent. So there's a question about maybe implementing this array and set up the Incereb with Neon with maybe some additional things like ECG, EKG, eye leads. Mm-hmm. So if someone wants to add on additional electrodes, so let's say the nurses overnight got this started and in the morning the tech comes in, can they add additional electrodes? Is there any issue with mixing electrodes in that case?
No, absolutely fine. If you've got somebody who is competent enough to put on extra electrodes, then that's absolutely fine. And for those non-EEG people, this is an ICU device. So really it's as many electrodes as we can get on quickly to monitor the baby's brain activity to see, number one, if the baby's having seizures, and number two, how many seizures are the baby having. Outside of the ICU, newborns can have EEGs done in an outpatient department if there's a clinical question, where they have a lot more electrodes applied to their head. So they'll have 24 electrodes put on their head. They'll have electrodes placed around the eyes, look at rapid eye movement in sleep, electrodes placed under the chin to measure muscle tone, and also EKG electrodes as well. And what this is for is to record activity of the baby to determine 3 sleep stages of the baby, which is awake, quiet sleep, and active sleep. And that's seen as, if those features appear in a baby's EEG recording, that's seen as normal. And the absence of them would dictate that it's abnormal. And so special attention is paid to rapid eye movement and to muscle tone and that kind of thing. But in the ICU, we're asking a different question. It isn't a diagnostic question. The baby is having EEG done because the baby's in trouble. And at that point, it's a seizure monitoring device more than a diagnostic tool. So, but by all means, if you've got an EEG tech who wants to put on more electrodes, they can do that. That's absolutely fine.
Great. Anne's asking a question, but Anne, can you clarify? It's about changing out I'm not sure her statement is, if one fails to adhere, we change the whole setup or cover with Tegaderm. So my question is, Anne, are you speaking about your experience in the past with this device, or just in general, you know, kind of what we have done in the past to fix electrodes that are failing? I'm not quite sure which way you're asking that. So maybe do you guys, Jim or Melissa, want to speak to, again, if one electrode is misbehaving, the steps you would take?
Well, the main reason that an electrode would misbehave and not work is that the wire has broken at some point between the cup at the top of the electrode and where it plugs into the amplifier. All the Neon devices are 100% quality checked before they leave the factory, and they're checked for conductivity. So it's very unlikely that you'll have one electrode broken on a Neon device. If an electrode isn't working for some reason, then the first thing I would do is I would change the cable, the connecting cable between the amplifier and the Neon device, which is an easy fix to make. And if that still doesn't solve the problem, then I would go and replace the Neon device with a second device. I would think it would be quite an unusual scenario if that were to happen. But I suppose the downside is you can't just change one electrode. You have to change the whole device.
Yeah. And that is true. Let's see. I'm just reading her question again. So yeah, so her question is just more about the stickiness. So Anne, I think what the answer to this, if used, okay, perfect, same question answer, is if one of them is misbehaving, it's more likely either an impedance issue, so scrub a little bit more for that particular infant, or to re-gel using some additional paste, and that should fix it up. But if it's a connection issue, then looking at the other component. But it looks like that question was answered. Anyone else have any other questions? You guys are doing awesome with all these questions.
Kathy, I have one thing I can point out while
Sure.
we're waiting. I know a lot of these babies that are being monitored are newborns, and they may have vernix or meconium on their scalp. The goal is, I mean, it'd be great if you can clean everyone's head off, but I know in an acute situation, you're going to want to make sure under each electrode spot where the electrode's going to go, you really clean that off. And visualize the scalp, do what you have to do, like, I don't know, warm water, just rub on that spot, dry it off, and then you can prep it. It's a little different than when you use a needle electrode, and you want to get that good low impedance. So that's what's going to help you to kind of get that cleaned off under each electrode spot.
Excellent. Yeah. I mean, I think that's pretty much, it should be everyone's standard practice who's using peel and stick or hydrogel or even cups, is you have to, it's awful. It's like one more thing we have to do.
I know,
right?
I know.
You can't give a shampoo in the middle of everything.
Sure.
But it really will make a difference for the connection, I think. And one of the things I've found that works really great, and this is like one of my favorite tips to give people, is when you're parting the hair before you do the prep, is go and find some toothbrushes. And I give full credit to UC San Diego, who I did a training there many, many years ago. And I said, oh, well, just give me your baby comb. And they said, well, we don't really have baby combs. We kind of have these little brushes. They said, but we have a toothbrush. Would that work? And I will tell you, it parts the hair the best ever. And I just get it a little bit wet, and then you can just part, and make the most beautiful part. And so if anyone's struggling with that, and even for needles, like, you can just get it a little bit wet and it just lays the hair down, and a little bit it gently exfoliates. For the super tiny babies, it's almost enough to just use that toothbrush. It seems so weird, but it works like magic. So I would recommend that to anyone.
That's a great tip. I haven't heard that one.
Oh, it's so good. It's amazing when you go to do it. It's like, oh my gosh, the hair just kind of flies away both directions, and you can really get in there to the roots and really, and you can really clean that out, especially if there is any leftover, you know, like older kids who have tappet and things. It works so well, and long curly hair just lays down flat. So give it a try, everyone.
Great.
Let's see, maybe, yes, Mohammed, that works on all hair types. curly hair, African hair, really thick Indian hair. I live in California, so we have a lot of Hispanic babies with really thick, dark hair. Just patting that, it works fantastic. Abigail's asking about the Stockinette. Does it interfere with cooling? Abigail, what kind of cooling device are you using? So typically, most places are using whole body cooling, and so the Stockinette does not interfere with cooling, and it should be fine. And many places are actually, once the baby reaches core temp, they're moving the blanket down to the shoulder level so that the head is not exposed to fluctuations in temperature. That's a whole nother real conversation, but you absolutely can use the Stockinette. We've used that at places I've worked for years. It doesn't interfere with the cooling because it's really the whole body. It's not selective head cooling, so you are totally fine. It's actually quite nice. It's actually better than using a full cap because it actually doesn't really warm at all. It actually allows the head to breathe quite nicely. So you should be good. And I think it's actually less, and Melissa and Jim, you could speak to it. You know, old EEG, you know, especially when we first started cooling, we would really wrap the head.
Mm-hmm.
I think that the Stockinette actually works, that open gapped, clingy thing that you showed, it actually works really nice. I'm not sure the real name for that.
I agree, and it's nice to let the scalp breathe, especially if you're going to leave this on for several days. If the wrap's too tight, it can cause pressure points with the older type electrodes, not so much with this, but we just don't need to wrap the head that tight. The babies are good with this sort of approach. It seems to work the best.
And Mary's asking about that stocking, the elastiband thing. Is it required to do some sort of wrap to help hold the paste in place, or?
Yes, I would highly recommend it unless you're just going to do like a 20-minute recording and it's fine and it's staying on. But, you know, you're going to have nursing care. You're going to have people lifting the baby. The humidity might be high. You want it to stay in the same spot for the whole monitoring. If someone accidentally tugs on something, you want everything to stay in place.
Perfect. So this is a little bit of a loaded question, but we'll go ahead and ask it because I'm sure other people are having the same question, which is the cost and kind of comparing that to needles. And how do you make the case to your hospital if this costs more than needles, which I think they probably do because I think needles are pretty cheap. But what are some of the other messages that you can share with administration if someone's needing to go up to bat? And of course, they're regional pricing, so I won't ask you to quote prices for all areas. So Mohammed, I can have someone follow up with you directly for your region, wherever you might be practicing, but maybe speak to some of the other things that people might share with their teams.
I'd like to take this first, Jim, and then if you want to jump in. What I've noticed when I've been training is it takes a lot of time for a nurse to measure the head and apply the electrode and plug it in. And it could be an hour depending on the baby's heart rate or O2 sats. If they're dropping when they're kind of touching the baby a lot, they could have to wait a little bit. The faster you can get this on, besides the obvious point, it's non-invasive. So, you know, why would we need to use a needle when we don't have to? The other thing is there's so much literature coming out now, overstimulation of the patient. And I know a lot of nurses will say, you know, I don't think it really overstimulates the baby to use a needle. And, you know, these nurses know what they're talking about. But what about when you remove it? And what about when you remove the tape out of the hair? That's when I've heard it's less comfortable for the baby. I feel like, yes, the price is higher, but also when you have every single nurse is in there measuring, it's very difficult to have every single nurse place the electrodes in the same spot each time. And are they symmetrical left to right hemisphere? Are the needles going in the same direction, or are they pointing them in every direction? Because if they're pointing them in every direction, that could cause an asymmetry on your brain monitor. So this is just a real safe way to go. It's a quick connect. So as long as everything's plugged correctly into the amplifier, if you have to fix things in between, you don't have to worry about confusing where things are plugged in. I just think it's a fail-safe method. It's a template. It's easier. Every single, if you know you use the Neon 12 on a baby, you know exactly what the measurements are on the Neon 12. And same with the Neon 8. So.
And I'll jump in here. I mean, for those of you that are lucky enough, I suppose, to have an EEG on call service where you've got techs that will come in overnight, from a hospital's point of view, it's cheaper to have the Neon 8 being used rather than pay a tech to be on standby and then pay their overtime and materials and electrodes to come in. For those using needles, yes, needles are cheaper. What we're seeing, there's 2 points I have on that. We're seeing more and more in the US where insurance companies are withholding payment and reimbursement for babies that have got what they class as bed sores, marks on the head left by needles. That's one thing which is in Florida at the moment, and I heard anecdotally that it's coming into more territories in the US from insurers. In Europe, for example, the needles use is widespread in hospitals. And in Germany, for example, a set of needles, it's about 25 euros, about $30. And those needles are every 24 hours, a swab has to be taken at the site of each needle insertion and sent to the lab for analysis that there's no infection, which adds to the cost of a 3 or 4 day recording. I don't know what it's like in the US. I don't think it's quite that stringent there. What we've also seen in Europe, by the way, at the other end of the spectrum, is we've come across hospitals in Eastern Europe that have needle sharpening kits where they reuse needles, sharpen them to use them on a second baby. So we cover quite a wide remit of hospitals that some have got funds to pay for devices and some don't have any money at all. But what I would say is that over a 4-day monitoring period, you're looking at less than $25 per day per baby using a Neon device, which is cheaper than having an EEG tech on call. It's safer on the baby's skin. You've got no issues with reimbursement or withholding payment, and it works. And we know, especially if you've got a hospital where you have a neurologist or neonatologist dialing remotely to check EEG recordings overnight, which is happening more and more. The one thing they'll always say is that at least they know where the electrodes are, so they can safely over an internet connection and look at an aEEG trace and say if it's normal or abnormal, because they know that the electrodes are correctly placed. So needles will always be cheaper. We can't compete with that. But this, I think, overall is a better holistic and a better neurological tool for using for a baby in neuroprotect.
Awesome. Yeah, I've also seen a lot of units whose volume of the infants who need to get monitored varies a fair amount, and it's hard to keep staff really consistent. And so as I go out and do aEEG training, these are questions I get every time is what electrodes should we use? And I think you guys have done a nice job of saying, this is a tool for your tool chest. It may not be the answer for every baby, but I have found for those units who have either staff turnover and keeping staff trained, and then limitations, and both of you mentioned it, is the limitation of access to techs, and even on-call techs. It may be 1 or 2 hours before they're able to come in, and be at your bedside, even in an on-call situation. If you're lucky to have in-house 24/7, we all are jealous of you wherever you practice, but most of us work in places where even with on-call service, it may be an hour or 2 before that tracing is started. And time is brain. And we know that the sooner we can get a handle on what the electrical activity is and be able to get these babies the care they need, we know that improves outcome, especially when we're talking about identifying seizures, identifying status epilepticus, and getting in front of that from a management point of view. So I think it's a tool. You have to look at what your practice is. You have to look at where the gaps are between what you would like to be able to provide for your babies and where you are, and just decide if this might be something that's worth considering. and making the case to your team. And you know, I just appreciate both Jim and Melissa being with us to share this product. We, you know, when we're at the trade shows and we only get a few minutes to really talk with the teams, it's hard. And so we have created these situations where we can give some of our corporate sponsors more time to really dive in so that you can, as at the bedside, make better decisions about what are the things that you need to fight for your unit to improve practice and to improve the care that we have. Jim and Melissa, both, thank you for your support over the years of Synapse Care. Thank you for your dedication and your passion to caring for babies and babies' brains, and for bringing these solutions to us at the bedside. So I just want to say thanks. And I think there is one more question, but I'll have you maybe connect offline, or maybe I'll just do it. Although that was a nice wrap up, but now I feel bad that I'm not going to answer this question. But what about a CPAP hat? Can you use that instead of the flexing net?
I'm just answering that question right now. It's yes, you
okay,
can.
Perfect. Okay.
Yeah, caps work very, very well. They're excellent. Yeah.
Great. Now I feel bad that I messed up my amazing outgoing message, but I didn't want Mohammed for your question to go unanswered. So anyways, again, thank you both, and thank you for what you're doing and for your time and for you know, being all of our partners around the world. So thanks so much, and have a great day wherever you guys are. And we'll post the recording for those of you who asked. It looked like you had some people you wanted to share this with. So
thanks a lot, Kathy.
Yeah, you're welcome.
Thank you, everyone.
Bye.
Bye, everyone.
Still raining in Dublin, just to kind of.
Still raining. Still raining in California too. So.
Okay, thank you. Bye-bye.
Bye.
Bye.